Good afternoon, everyone, and it looks like my time is up, so thank you very much. My wife asked me to do a project. She said, can you put a fan in the downstairs bathroom? I said, sure, no problem. So a significant laceration, nicking the tendon later, I'm here. By the same token, my boss's boss said, hey, can you come do a project? Go up to RightCare, say something. I'm like, okay. So I'm hoping this goes better than this. All right, so we're going to actually, for sake of time, we're going to come back to that at the very end. All right. So we all know this is basic. Heart attack and strokes are huge drivers of death and disability. We're looking at this not just in any one situation, but for all of us across the U.S., across California, and in Kaiser. But Kaiser has an opportunity. We have an integrated system, and we want to use that to leverage everybody working together to try to reduce these events that are going to cost not only our patients, but also us as an organization. Just quickly, top 10 causes of death in high-income countries: ischemic heart disease, stroke leading to, diabetes way up there as well. But this is our trend. This is looking over the last 10 years, from 2000 to actually 2014. MIs over the last 15 years. So we want to keep this going and keep going in that direction. I'd love to get to the point where we can say there are no MIs happening at Kaiser. We'd love to actually be part of a group in San Diego that says, look, there are no MIs, there are no strokes happening in San Diego. The journey, though, we weren't always making good trends. Once upon a time, we were actually doing very poorly. Yeah, we thought we were great because we'd all compare ourselves to ourselves. We'd look at our organization and say, wow, my clinic's doing a little bit better than your clinic. And we'd be really happy, and the clinic that was a little bit worse would feel a little bit bad. But we'd all compete and, wow, congratulations, you got to a 50% hypertension control rate. And we'd just feel great. Suddenly this national data started coming more and more available to us, and so they're like, oh my goodness, we're not great. We're sort of average, below average. And for pretty much everybody in this room, none of us ever went into anything we did to be average. None of us said, okay, I want to see. Didn't happen. So about the year 2000, one of our endocrinologists, Jim Duddle, who's been up here and has presented up here before, came to us and said, look, I need for diabetes for you guys to start a program called ALL, A-L-L. And I want every patient who has known CVD or diabetes to be on aspirin, lisinopril, and lovastatin. And it's so important that we do this, we're going to make it easy. We're going to give you a pre-printed, back on the days of paper, prescription that had all three of them written out. Just put in the patient's name, sign your name, it's done, the patient gets what they need. So we did. He came and trained us, he said, this is why it's important, this is why we need to do it. So we said, okay, you made it easy, we can do that. But we also then took a step back and said, but these are lifestyle diseases. These are behavioral diseases. How do we promote these to improve and keep having that discussion? And that is an ongoing process. It's not something you can do overnight and just get accomplished. And so we're still doing training. We're doing training on motivational interviewing. We're working on our doctors, getting to understand that system of helping the patient overcome their own barriers. We've been teaching on healthy plate promotion. Love the lunch that we just had. Great healthy food. Bravo, thank you very much for helping arrange that. But a picture is worth 1,000 words, because a lot of our patients don't necessarily understand the 1,000 words that we try to give them. And so a picture of a plate, or actually we gave all of our primary care doctors an actual plate, right size, divided into the right quadrants, and said, show your patient this. 4 basic groups. I'm going to go through this really quickly. ASCVD known, start them on high-dose statins. LDL greater than 190, start them on statins. Diabetes age group, 40 to 75, specific age group. A-risk over 7.5, high dose, less than 7.5, low dose or moderate dose statin. And then the 4th group, those with high A-risks, should they be on statins. And it's an interesting, you can't start anybody on a statin unless you discuss the statin, but those in the high group, start the statin, discuss the statin with the middle group, and then consider a statin in the lower group. It's sort of one of those vague things, I'm not exactly sure what it means. But this is where we've gotten to in Southern California, at least as of last month, compared to national groups with these 3 major groups. So looking at aspirin, you get about based on an Archimedes model, about a 17% reduction in ASCVD risk. The statin at 40 milligrams, about a 42, and combined, you can get about a 54% reduction in events. Latest thing that just came out from United States Preventive Services Task Force, their guidelines for aspirin have changed again. We have to keep learning, we have to keep understanding, hey, these aren't just static measures. And one of the challenges is, how do you keep training somebody, okay, we told you that was right last week, now it's wrong, we got to change and do it a different way. So the age group 50 to 59 with a high risk, for patients without ASCVD, but with or without diabetes, is now start aspirin in that specific age group, 50 to 59. 60 to 69 is now discuss aspirin, and then here's some of the data that goes along with that. We can see that the prevention stays fairly constant. You get a net life gain in the 50 to 59 group, a small gain in the 60 to 69 group, and that's why those two have different recommendations. But motivating a patient to take a medication is always difficult. There's very few patients that just say, wow, give me another pill, please. And so you have to use opportunities. When the patient had an event, when they had a hospitalization. Just because they say no, though, doesn't mean you don't keep encouraging, because sometimes events change that you didn't know about. And so using those times to have that discussion. And then dispelling myths. Oh my goodness, if I go on that medication, horrible things are going to happen to me. And helping them understand, well, gee, there's also disease that's going on that we're trying to help you with. We use pill boxes, give those away. Saying, hey, use this to help you remember when you're supposed to be taking it. Tying something that they always do to when they're supposed to take their medications. One of the things that we've used a lot of is something called the proactive office encounter. It really helps the doctor to have information just when they need it. Patient shows up to see the patient shows up to see the doctor, and the doctor right there, without doing any work, has the ASCVD risk score right available for them. Different patient, using the care management summary sheet, it tells the doc, hey, this patient with this risk might want to start lisinopril, might want to discuss having aspirin with them, and it didn't say anything about atorvastatin because it already recognized that prescription had been written. You get the patient convinced, they start the medications, great. They come back, are they taking it or not? Well, you can have a lengthy conversation to say, gee, are you really taking it? Are you taking it just like you're supposed to? Are you taking it every day? Are you sure you're taking it every day? But this actually makes it much easier, where you can say, all right, medical reconciliation, how often they're taking it in percentage. This person is taking it 100% of the time. That means they refill it on time, every time, and we consider anything above 80% to be adherent to the medication. Last thing you need to do, though, is engage the patient. Our patients are now getting an online personal action plan where they receive, through an email, hey, go check your website, or check our website for your record, because something's changed. Sometimes it'll be, hey, we got new lipids back and your heart risk is this. Or sometimes it'll be your colorectal cancer is coming due again. It gives them action items that they can take. And then sometimes we'll say, hey, you need to talk to your doctor because there may be interventions that your doctor needs to help you with. Huge savings, we've already talked about that. But one of the other pieces that we have used is having the pharmacist start to engage. Patient shows up, didn't see their primary doctor, didn't call in, or just wanted their medication refilled. For whatever reason, they called in to get that done. If they show up to see the pharmacist happens to notice that adherence rate is sitting at 60%. They're filling it today, but for some reason they're not filling it regularly. The pharmacist then will do an intervention with the patient, identifying barriers, trying to help figure out what the patient's doing, work on solutions and motivation, adherence tools, relationship building, both for the patient and the pharmacist, but also for the patient and the primary care team. We also then have the pharmacist help connect them to the other parts of the healthcare team using health education, nurses clinic, all these pieces that are in place. So, in summary, it's an ongoing journey. We are not there. We've had good improvements. We've had improvements from 50th percentile up to 90th percentile. One of the examples that I wanted to bring up, because Hector brought it up earlier, was our use of the retinal camera and making sure that our patients are getting diabetic retinopathy screening done. We're sitting up top 5 in the nation. How do we do it? Every single primary care building has a retinal camera in it. And a patient comes in and the flag shows up that says, hey, this person's due for a retinal camera, or due for a retina check. Our back office staff preps them when they see us, potentially puts the drops in before they even see us. We see the patient. When we're done, they go downstairs, they get the picture done, and they walk out. We don't ask them, do you have eye benefit with us or not? Taking care of the retina is part of taking care of diabetes. And so we do it for every single patient, every single time when they need it. We're going the right direction. I'm excited about where we've come from and where we're going to. But I'm also excited because we have partners with Be There San Diego, Kaiser, Sharp, Scripps, UCSD. The team in San Diego is coming together to try to help all of San Diego get better care. As we learn new things, as we learn new studies, we have to continue to push these forward for our patients' benefits, for our own benefits, for our organization's benefits. And so I just thought these two pictures are going to either help each other up the mountain, or we're going to be like Sisyphus pushing the mountain up, rock up, and letting it fall back down.
Great. Thanks a lot, Brian. Since we are running a little bit behind, we're going to hold off on questions now. So I would ask Dr. Solomon, before I don't know how you're going to tag team, but you guys are up. So MemorialCare.
One of our really high-performing IPAs. Thank you so much for telling your positive story.
Well, thank you so much for having us. I'm Adam Solomon, the Chief Medical Officer of the MemorialCare Medical Foundation, and this is Andrea DeCoro. She's the Executive Director of our Clinical Pharmacy and Performance Improvement Department, and we're going to talk about our story on how we've addressed diabetes within our IPA. Just to give you a little bit of the structure for our organization, for those who aren't familiar with MemorialCare, we're an integrated health system with hospitals, a very small health plan, physician division, and so forth. In our physician division, we have both a medical group and an IPA. This is our geography. You can see from southern Los Angeles County down through southern Orange County, our hospitals, and then the orange is our central services. And surrounding all that, we have doctors' offices, urgent cares, ambulatory surgery centers, and a joint venture with Fresenius for dialysis. And so a few years ago, we had just questioned, is there a program that we can put out that will help our patients and help our physicians with an area of need? And we wanted to have this to be a team-based approach and recognize the need in diabetics. Because our primary care physicians really need help in managing some of the more difficult to control diabetics. So we started with this vision and put forward the team. And as everyone's aware, diabetes has been a difficult disease to control. It's associated with so many comorbidities, and the problem really has been growing over the past several years, continues to expand. And diabetics, because it is a multifactorial disease, tend to need a slightly different approach than sometimes some of the singular diseases. And it is something that our primary care physicians and even endocrinologists really don't have the time to adequately address. And so the outcomes had not been doing so well. And it's also an area where we recognize that having a multidisciplinary team to approach this complex problem would result in much better outcomes than it would be just by having this standard doctor talks to the patient, tells them what to do, and they manage it that way. So we wanted to have a centralized program with a multidisciplinary team, and we wanted to focus on the patients that were inadequately managed despite at least 3 months of effort by the primary care physician. And that was really the only requirement for them to be referred in. And the team was going to address not only the diabetes, but all the comorbid conditions associated with diabetes, and that the care would be individualized based on each patient's specific needs. But this did require the PCP referral because the primary care physician is, of course, an integral part of this team, which does not have a physician or nurse practitioner on.
So I'm going to talk to you about how the program works, but before I start on that, I just would be remiss if I didn't point out how funny Shelley's comment was earlier this morning when she said, oh, who are you trying to kid? Nobody is Hattie's boss. And those of us that know her got a good chuckle out of it because it's really through her tireless and relentless pursuit to improve the healthcare for the citizens of California that we're all here today. And really, she's more of a leader. And so in some ways, she's actually our boss, even though she's not listening to a word of this. I hope this is recorded.
Sorry, we were conferring.
Well, I just informed everyone that you were our boss.
That's quite a joke.
All right.
This is a we thing. This is the Right Care family. We're all figuring it out together.
That's right. All right, so how our program works. So first of all, there are two things that need to be in place initially. One is around PCP alignment, and we do that through incentivizing the primary care physicians, specifically in an area that you want them to put a great deal of focus upon. The other thing is to create a solution to solve a problem which they can't solve by themselves. And so the poorly controlled diabetic population is poorly controlled for a reason, and there's not a single primary care physician or endocrinologist that I know of that has the time, energy, or resources to address all of their different, very unique needs. So we set about to create a team that they would trust. We already had pharmacists embedded in some of the clinics with the anticoagulation and the post-discharge clinic, so it was a natural fit to start with diabetes, and we added a social worker and a dietitian, and I'll go into a little bit about their specific roles. So once you have those things in place, really to make it successful is that the PCPs know at any given moment their patients are closely followed and monitored, and that you are diligently tracking the results of the program. You're reporting those results out to the physicians that are making the referrals and also to the key stakeholders within the organization. And last, but certainly not least, is making sure that the primary care physicians are kept apprised. Oftentimes, well, after every visit, they'll get a note, but oftentimes if there's a particular question or if a recommendation is going to be made that's kind of out of the norm, the PCP will be contacted, and they appreciate that. So this is the team. The three, in the beginning, the clinical pharmacist, the dietitian, and the social worker are the team members that are responsible for running the program and for the outcomes. We do have a medical director. She's not on site, but she is available for consultation. We specifically picked this team because we wanted someone to address the medication management, someone else to address the nutrition, and lastly, someone else, but certainly not least, to address the psychosocial barriers. So the pharmacist's role, as you can imagine, is around the medication management, but actually they play sort of a quarterback role in that they know when to triage certain issues, and then they will create individual care plans to help improve the patient's blood sugar and blood pressure control. They do that by critically assessing a patient's medical history, looking at drug-drug interactions, drug-disease state interactions, and even for what's most affordable for that patient. They help with adherence to statins, referrals for eye exams. They can do the microfilament test. They prescribe and make referrals when necessary. The social worker, so diabetes care is the bread and butter of primary care, right? So 95% of the time, they'll do a fantastic job with that population, but there's a small percentage of patients that no matter what they do, no matter what the endocrinologists do, they just can't get to goal. And we think the reason for that is due to some psychosocial barrier. For some patients, it's complete denial that they have diabetes. For others, is they're so busy taking care of their families, parents, working, that they don't think they have any time left to take care of themselves. And so I would like to say that the social worker has some kind of Jedi power to really get into their brain to figure out what it is that's preventing them from getting to goal, and from there to create an individual care plan to address whatever those barriers are. Working with the patient to come up with goals that the patient can actually adhere to. They also do depression screenings, And they really become, they have a great rapport with the patient and the family. They become a very good support system for everyone, and all the way down to calling the patient and wishing them happy birthday. The dietitian, very important role in terms of explaining in terms the patient can understand the importance of nutrition and good diet. We'll look for areas of opportunity based upon what the patient is able to accomplish. Sometimes it's very small goals and building upon those goals. And what's new for us is that the PCPs are so excited to have this new dietitian that they've asked that she start seeing patients that are newly diagnosed, hoping to catch the disease early on in its progression and make a bigger difference sooner. Sometimes we're asked what the PCPs think about the program. The question was specifically around the pharmacist's role. I'll just read one of them. This is from Dr. Coyne, and he says, "I don't think I can stress enough how much more the PCPs value the care given to our diabetics by the pharmacists in active diabetes than by the endocrinologists, whose resources to track and educate our patients are just as limited as the PCPs. There's better follow-up and better results." And now I'll hand it back over to Dr. Solomon to go through the results.
So just the last minute or so, just to review the results from this program we've had in place for just a few years now. And so although the program is addressing just the more difficult to control diabetic population, this is the results for our entire diabetic population. Right? Oh, sorry, no, this is just the active diabetes patients. So these are the patients that were all had to have an A1C above 8 when they came in. Initially, it was above 9, and we lowered it to increase the referral rate. But you can see well above the 90th percentile for A1Cs below 9 and below 8. Blood pressure control also well above the IHA 90th percentile. And nephropathy screening is at 90%. It's a tighter band for results, but also doing well on that. And that is,
We got our little signs, so
I know.
that's all presentation.
It's time for
We have time for a couple questions. Quick questions? Yes, Brian.
How many patients do you manage with that team?
350 and grew to 500 this year, so for the first 3 years.
With one pharmacist and one of each of those?
Yes.
at one time.
The patients, will graduate out hopefully at some point in time.
Other question, anyone? How would this work?
How do you incentivize the PCPs? So you mentioned that, I'm just curious.
Financial incentive.
They get a target, they get a...
And it's similar, there's a set of goals that we have for the primary care physicians for things that they're going to be doing, and they get rewarded for hitting the target.
Okay, last question right there.
Do you push or pull? Do you run a report, anyone above this gets automatically enrolled?
So this,
But it's actually, the only way into the program is through a primary care physician's referral. We tried initially when we first rolled out the program to call patients that were poorly controlled, we're talking like 10s or 11s, and say, hey, we have this great program, your PCP really wants you to come. I don't know who you are, and so we didn't get anywhere. So now it's the primary care physician drives everything.
and part of it also, this is an IPA, and so the physicians do feel like they're my patients, and although they appreciate the assistance, they want to control that referral. So we do give them lists of patients. They get the option whether or not they want to refer the patient into the program or not. Somewhat different than we do with a medical group, where it's a little bit easier to say, these patients are going to be in. For our IPA, it's voluntary, the physician refers the patient. And also it does add, when the physician says, I'm going to refer to this program, it's an excellent program, and then they're part of it. It helps a lot for patients' compliance.
Very good. Thanks again.